but want to thank everybody for joining us, especially on a Saturday for our first in a series of webinars. I'm Brian Patterson, going to be serve as, I guess, your host for today, and we're really excited about what's bringing us together. We're launching the 30 side view IntraView scope, the first sub 2 millimeter rotating needle scope that's disposable. It's the newest addition to the IntraView family, and we're already gathering a lot of excitement about the product. So Dr. Bush with Resurgence Orthopedics here in Atlanta, definitely a friend of the family, who's contributed a great deal as far as our product design and development, and directing us on how we should approach this product in this market. He's kind enough to lead our discussion today. He's going to talk about some of the advances in needle arthroscopy, how he's been able to integrate it into his practice, and then his thoughts on the new addition with the 30-degree scope. We'll keep this pretty informal as Dr. Bush goes through. He actually does an excellent job of fielding questions on the fly. So as things come up, if you do have any questions, please participate. And without further ado, I'll hand things over to Dr. Bush.
Well, hello all. Far too much credit was given to me with regards to the skill which I'll muddle through this, but I do echo Brian's thoughts that if any questions do arise as we're going through this, please don't hesitate to jump in. As Brian indicated, I'm a board-certified sports medicine surgeon with Resurgence Orthopedics here in Atlanta, specializing in predominantly knee and shoulder reconstructive and arthroscopic procedures. Next slide, please. So excited about today, excited about this new era for IntraView as a company, because we are launching the new 30-degree side view scope, which, as Brian indicated, is the first sub 2 millimeter disposable 30-degree rotating single hand ergonomic needle arthroscopy device out there. Field of view quoted 120. I think it may be a little bit more, but I don't want to head my bet too much there. So one of the really interesting aspects is that the swivel for the flush port seen on in the image there, the white port moves independently of the actual sheath, so it makes it a very useful adjunct to the product, such that your syringe for air insufflation is not dependently moved with the scope. You capture extremely excellent image qualities, HD and video quality as well. On the next slide. So I have the kit here with me as well, but this is just a depiction of it showing what comes in the new kit. There's a sharp and a blunt trocar. The standard cannula is roughly 2.2 millimeters with a rigid cannula that's slightly more stout at 2.5 millimeters, as well as two-way stop valves for not only aspiration of joint fluid, but also insufflation of air as you're going through the procedure. There is a tablet that your local representative will be bringing in to you for your cases, and allows for horizon leveling technology, such that as the scope is rotated, the image remains stable in the horizontal plane. It also allows the physician to be able to rotate the field of view without repositioning the device, which is a key component, particularly for shoulder procedures, allowing you to look around the corner, a previous limitation of the 0-degree scope, but also minimizes soft tissue disruption as far as having to angle your hand either up, down, left, or right to allow for visualization of different portions of the joint or space that you're looking that you're viewing. We can advance. So this is using the knee model, and this is just demonstrating if you find the checkered point on the top right corner at this point, and it's allowing for the provider to rotate the scope to see different portions of, in this case, the knee, without necessarily having to change their hand position as they're doing it. So just a very neat aspect of something so small that really mimics the traditional arthroscope, which is something that I'd longed for past 2 or 3 years that I've been using the IntraView product. So I'm very excited about this new phase for us. The next slide. So terminology needle with an I has followed the InterView system since its inception. Single-use sterile device now with 30-degree side viewing capability with rotating scope with a roughly 1.9 millimeter outer diameter for minimal invasive procedures. Image quality, having used multiple other products in the past, I would say is top-notch, best I've seen. Definitely can be utilized with single hand ergonomics without the need for placement of your other hand for rotating the actual direction of the camera. It is readily reimbursed for the knee, shoulder, hip, elbow, and ankle is coming along. Go on, next slide. So it is an excellent, not only in office potentially, but definitely an ASC diagnostic device. It's really, really useful for non-invasive diagnostic purposes in lieu of MRI, and folks that can't have an MRI either by virtue of spinal cord stimulators, stents, claustrophobia, or any reason that they may not be able to have a test like an MRI. The InterView device allows for you to predictably get a good assessment of intra-articular structures in the situation of what we're talking about right now for diagnostic purposes to allow for better and more accurate treatment of the patient moving forward. A really, really useful aspect of the device is for the delivery of regenerative medicine products, such as PRP, stem cells, and bone marrow aspirates directly into the site of injury and under direct visualization, not only for confirmation that you've placed your product exactly where you wanted, but this can also be demonstrated and shown to the patient when they follow up in the office, or if they happen to be completely awake in real time. Postoperative assessments, useful in situations where a procedure has been performed, whether or not it's some sort of repair or cartilage procedure, and there's question as to integrity of the repair or integrity of the cartilage growth. This is a very, very minimally invasive way to confirm or disprove that healing has occurred or if any new pathology does exist. Next slide. Extremely safe, as mentioned on several occasions. It's a very, very small device akin to the tip of a pencil or pen. So you'll see in upcoming videos that there is either not a need to make any incision whatsoever, or at most a small stab incision with use of an 11 blade. I don't use any stitches at all. It's really not indicated or needed in any circumstance. Simply Steri-Strips over the small portal site and spinal needle entrance point. I use local anesthetic with plain lidocaine for my cases involving the knee and the shoulder. And I can honestly say to this point, at least 50 to 75 cases in, I haven't had a complication such as any sort of infection or any sort of hardware complications or anything of that nature. So it's an extremely safe product to use. The next slide. So I won't belabor the point by going through each of these codes individually, but you can see on the screen the CPT code that would be applicable to the joint in question, whether it be shoulder, elbow, knee, wrist, or hip, and the associated facility and non-facility reimbursement rates and ASC reimbursement rates, which is where it becomes a very, very useful tool. And actually, if you are, or the provider that you are speaking to has ownership interests within their ambulatory surgical center, it is a means to have a profitable margin. And I'm sure Brian will go into detail about that when I'm done here. But it's definitely been a welcomed and an accepted tool within my ASC, not only by myself but by a couple of my partners. The next slide. So I just want to talk a bit about portal placement for knee, shoulder, and hip. As mentioned before, my world is predominantly knee and shoulder arthroscopy. So, the workhorse portals that I use will tend to be the anterior lateral and anterior medial portals just adjacent to the patellar tendon, roughly a centimeter outside, either medial or lateral, and the soft point within the joint just distal to the inferior portal of the patella. Uh, and then also the superlateral and supermedial portals are going to tend to be the most likely utilized accessory portals, either for the purposes of injecting whatever product you happen to be injecting at that time if you choose to, but also gaining access to probe other structures that are visualized during the time of your arthroscopy. The next slide. So just a couple of slides about common knee pathologies that you may see at the time of a needle arthroscopy. Just for orientation purposes, everything is obviously labeled. But in this situation, there's a degenerative tear of the medial meniscus with the underlying tibia showing some early signs of chondromalacia, thinning of the cartilage. And then on the slide to the right, there's a more pronounced cartilage loss on the femur and tibia with kissing lesion. This would be someone that would very much so be classified as end-stage arthritic changes. Next slide. So moving on to the shoulder, there are a couple different ways the patient can be positioned for a shoulder arthroscopy. If anyone is on at this point that does do shoulder arthroscopy, there's a traditional beach chair and lateral. I scope in both orientations, but for the interview device, I will tend to use the beach chair position. And again, in that situation, in any situation, the workhorse portals are going to be portal number 1, which is your standard posterior mid-glenoid arthroscopy portal, and then portal number 5, 6, just kind of depending on where you're going, the range, and where you're looking to access as far as your accessory portals for spinal needle placement or injectable products. I could run through and label each of these portals, but I think those are the two to really keep in mind when talking about where you're going to be injecting prior to your case, because I don't do general anesthetic for these cases, nor do they get blocks at all. I'll do a MAC anesthetic with use of propofol, with our nurse anesthetist doing a fantastic job with that. And then inject the portal sites as well as the joint, which there'll be some video of that coming up here. So we'll go next slide. Again, everything labeled for us, but nice view of what a right shoulder in the situation of the slide on the left, and then again, a right shoulder on the right. But on the left, the patient is in beach chair position, more than likely, and on the right, they're in lateral position. So just the structures that can be visualized, the anterior labrum, in this situation, as well as the subscapularis labeled SSC in front, and humeral head, glenoid, rotator cuff above, and biceps tendon above, and biceps tendon is labeled clearly on the right. The beauty, and actually the really, really exciting thing for me, and unfortunately, I didn't have any cases this week, or else I would love to put them in this presentation. I have a few cases coming up in the next couple of weeks, but just the ability to be able to rotate and look around the corner, particularly in the shoulder, is going to be very, very key with regards to properly visualizing, the rotator cuff, the labrum, really being able to see inferiorly within the infraaxillary recess, looking around the corner at the subscapularis, really getting a sense of what the cartilage structures look like on the anterior humeral head. It's really, really going to be a nice tool that I'm excited to get my hands on with a live patient. We'll go next slide, please. So for the hip, oftentimes hip arthroscopy, well, every time hip arthroscopy in the traditional sense is performed with the hip under traction. As you'll see again in upcoming slides, I will traditionally do shoulder cases with the use of some sort of traction, but I do not for these cases because the patient is not fully anesthetized. Same thing with the hip. There would have to be, perhaps mild traction, and perhaps a little bit more sedation would be needed for hip patients, but your working portals are going to be 0.11 to enter just over the greater trochanter into the hip joint, and then your accessory portals would be Y and X as far as getting in there to visualize the anterior portion or do some work on the anterior portion of the femoral neck and the anterior labrum as well. We'll go to the next slide. So this is just a picture of the setup. On the left is pretty much the standard setup for either knee or shoulder for me. I'll have a kidney basin available for any sort of joint fluid that is aspirated. I'll typically have some saline available for any sort of lavage that I may want to perform. In this case, there's a PRP injection that's already drawn up there. The larger syringe is for the local anesthetic that is injected prior to the case. You have the IntraView device, two additional syringes for the purposes of insufflation of air or aspiration of the joint, a Coban, and then Steri-Ships that are applied at the end of the case. And that's really it. There's nothing else that I use or really need. During the case, I will have a scrub tech with me. I don't have a surgical assistant. You can see on the right, very minimal draping is needed, or that I use. And that is all for the purposes of minimizing costs in association with disposables to the ASC. So in this case, I just have a standard U-drape, stockinette with a Coban over the patient's forearm. Patient is completely, they're, quote, awake. There is IV sedation going, but there's no ET tube or LMA or block or anything of that nature. And then the tablet is set up on the contralateral side from which you're working. So we'll go next slide. And for the knee, again, the back table setup is much the same as far as what is available for my use. Again, the tablet is set up on the contralateral side from where the procedures are being performed. Exact same setup, one U-drape, one stockinette, one Coban. I do gown and glove for these cases simply to dissuade any limitations with regards to being able to move or position the extremity. I want to be sure I can do everything I need to do. So I don't want that to be something that limits me. And for knee cases, I do have a side post on the bed to allow for me to drop the knee down and have it be bolstered in some way. One point about the shoulder, I do have a beach chair positioner that I use. However, I think this could easily be performed on a stretcher if the patient is just elevated a bit, typical Fowler position, maybe 60 degrees or so for the beach chair, and that allows you to have access to the posterior shoulder as long as you can get to the point that is roughly the midpoint of the medial to lateral thickness of the acromion that allows for proper access to the posterior aspect of the glenohumeral joint. We'll go next slide. So as stated before, local anesthetic I administer on the field once the patient is draped and ready to go. So injection into all potential portal sites. So for me, as mentioned before, that's going to be the medial and lateral portals just distal to the inferior polar patella, adjacent to the patellar tendon, and then the superior medial and superior lateral portals as well. Roughly 5 to 10 cc's wheel is raising the skin, and then the rest in the joint. So it ends up being 30 cc's overall, probably about ends up being 15 cc's in the joint, the rest in the soft tissues. And then I'll range the knee or shoulder a few cycles to allow for the local anesthetic to circulate. So I think we have some video here of that. Pay no attention to the bulging biceps as the local injection is going in. So this is just mid portion of the patella, just below into the joint. Put a little more in there. So once the injections are completed, hopefully we got a little video of the knee being ranged, maybe not. Okay, fine. So we'll move forward. So image quality with the interview camera is really fantastic. In this situation, there's a bit of fluid in the knee. If you can really get the joint really dried out and working in a purely air environment, your image quality is truly outstanding. I think we have some video of that coming up here. But in this situation, we have the femoral condyle above, tibial plateau below, meniscus in between on the left, normal looking meniscus on the right, meniscus tear, and small loose body. We'll go next slide. This is sort of a midpoint between a completely dry joint and a joint that maybe has a little bit of blood in it, either from patient's pressure maybe going up a little bit as the procedure started, versus your injections as well. And you're going to have situations where you have to work through things a little bit to get the visualization that you're looking to be able to see. So obviously patella on the left and condyle defect on the condyle on the right, with underlying meniscal pathology minimally on the image quality, or on the image to the right. Go next slide. So here we have some video of a case, and this is me. So we have the ACL we just came across. We have the medial meniscus. Can we play that video on the left one more time? So we have the medial meniscus in the situation here, looking pretty good. We have the condyle, femoral condyle above is tibia below, string cross, ligamentum, and then ACL. And then the video on the right is in the patellofemoral compartment. We have the spinal needle coming in from the anterior medial portal. And this will just show direct video of the PRP injection as it's being injected, in this case for someone with patellofemoral arthritic change. So this is that same patient that we had previous video on, or images on, as far as the setup of the back table and positioning. So in this situation, we're actually getting the spinal needle into the joint. I do a little bit differently for shoulders. I put a spinal needle directly into the joint after raising a wheel in the portal sites, and that allows for me to inject the local into the joint. Shoulders a little bit deeper, so that's why I use a spinal needle to be sure that I'm deep enough. And then 11 blade to just make a nick in making the skin posteriorly. And then we have our sheath and trocar. We'll get that in the glenular joint. So you'll see the patient's not under any traction. She's not having my assistant pulling on her arm. There's no traction device that's being used. There we pop into the joint, right there. And then we switch the sheath out, or the trocar out. So now we have our camera in, and we have syringe, and we're pulling some fluid off the joint. So in the tablet on the left, we can see the humeral head on the left. We'll have the glenoid on the right. Again, just working to pull some fluid off the joint so we can really visualize and see clearly. There's the biceps tendon coming across the top there, and then the leading edge of the supraspinatus on the top left corner of the tablet on the left side of the video. But this is the point I wanted to make. It's going to be really a nice adjunct to be able to swivel that camera to the left and just be able to look top left and see the rotator cuff much more clearly with minimal motion of my hand. So we'll go next slide. Images from the shoulder, humeral head left, posterior labrum to the right. And then as you push further into the joint, you have the subscapularis coming across right about the horizontal point of the image, and then a bit of arthritic change, the anterior glenoid on the left and humeral head on the interglenoid on the right, humeral head on the left, and the rotator interval, which is where your spinal needle will typically come in from that portal 5 or 6, as we mentioned previously when we were talking about the portal positioning for shoulders. The next slide. This is a video of that patient's PRP injection. Again, spinal needle in the rotator interval. We have the superior labrum on our right, and we're directly in the glenohumeral joint where her issues lie. But this is certainly a situation where if you had someone with a superior labral tear and they were not interested in repair, we actually just had this conversation yesterday with a patient about the option of doing a PRP injection into the superior labrum to facilitate healing. It's excellent adjunct for folks with a partial thickness rotator cuff tear, such that you could inject on a direct visualization into the area of the rotator cuff that is partially torn. Definitely a lot of applications from the shoulder. Go to my next slide. So one case study here, I believe, 65-year-old gentleman, 2-month history of posterior medial knee pain, meniscus tear for MRI, wanted to avoid surgery. Interview confirmed condyle lesion, medial condyle, as well as meniscus tear, and then subsequently targeted biologic injection at the tear site, as well as covering the condyle lesion. So I think we have images and then a video. Gender change, medial femoral condyle above horizontal oblique tear, radial component, meniscus tear where the spinal needle is located, and then still shot of biologic delivery there. I believe that was PRP. That was slightly blood tinged there, but that's the injection actually in place. And I think there's a video maybe on the next slide. Yes. So one question that I'll get from time to time is whether or not you can simply just inject down the sheath of the interview device. And I guess in theory you could. It's not recommended to do so. A more targeted procedure like this is more advantageous. And also the sheath and camera itself, you could lose a small bit of volume, somewhat inconsequential within the actual sheath and camera lumen. All right, we'll go next. I think that was the last slide. Yes. Okay. Well, thank you all very much for taking the time. If I haven't put everyone to sleep, I'm happy to take any questions that anyone may have.
Yeah, thank you, Dr. Bush. We really appreciate your sharing your knowledge and sharing the experience there, really kind of sharing how you set everything up and utilize the device in your practice. So we will open up the floor for Q&A. Brian, if you can kind of make sure everyone has access to unmute themselves and participate, and we'll open up if we do have any questions from the audience today.
Yeah, and before we do that, maybe Brian Patterson, I'm not sure if you wanted to say a word about the billing and CPT and all that sort of fun stuff.
Oh, yes, absolutely. So thank you. I appreciate you reminding me about that. So that is one of the big advantages of utilizing the interview scope in the current status. We're not doing anything unusual or new. We're not using any type of unlisted codes, et cetera. We are able to use existing CPT codes. So for a diagnostic scope of the knee, for example, 29870 is a pre-existing code that physicians like yourself are quite familiar using. We do have the ability to do these procedures in the ASC or in the office. Most often, we are using the ASC. Patients, like Dr. Bush said, tend to be a little more comfortable when you have additional access to levels of anesthesia, not quite requiring general anesthesia, but doing the MAC anesthesia, and the patient comfort level is certainly improved. The other advantages from a financial perspective, it is advantageous to bill in that environment. But we do have to see coverage for commercial insurance. We see coverage for Medicare, and then we also see coverage for personal injury and work comp. So I'm definitely happy to answer any specific questions regard to the billing, and also our representatives on the line locally have additional knowledge as far as reimbursement on the local level.
How's the patient's acceptance been of the procedure? Very well.
There has been a significantly high level of patient satisfaction. I will say that with rare exception, most patients will come back indicating that within the first week after the procedure, I do PRP injections, they have noticed a level of improvement in their overall pain quality. And they're really happy with the notion of really not having any incisions, no need for post-operative physical therapy. It's really been overwhelmingly positive with regards to the feedback I'm getting.
Is there any specific, say for knee chondrosis, when you do PRP, they've had physical therapy and they've failed that, they're still refractory. Is that the type of patient population you may do PRP in, or a small meniscal tear in a younger person?
That's absolutely correct. So, you still want to follow your proper protocols as far as what most insurance carriers are going to want to see, which is failed conservative therapy, typically 6 weeks, either and anti-inflammatory medications and physical therapy. The huge cadre of patients that seem to gravitate towards this procedure, and partially that's because they've either heard about PRP or they've done their research about devices like the IntraView needle scope, is that patient's in that tweener stage, so somewhere between 50 and 60 maybe, active, want to remain active. I live in a country club community and I see a lot of golfers, and they don't want to acquiesce to knee replacement. They want to try everything possible before they take that cold jump into the pool for either knee or shoulder replacement. So this is an excellent tool for them to give them some improvement and improve their quality of life without asking them to commit to months of additional rehabilitation after this procedure has been performed.
Can I ask another question about shoulders? So you see a patient, they say they have a small partial biceps tear proximal, a small labral tear, and the same thing, don't want to go through a repair. Are you having good outcomes? And the other question is acceptance, say, with a workers' comp insurance. Is that variable from your practicing in Massachusetts, or?
No, I'm in Georgia, and in Georgia, workers' comp has actually been very overall amenable. Obviously, insurers have their different algorithms as far as how they go about approving various interventions, whether that be MRI or procedure of this nature. I've certainly had to jump on the phone and do a peer-to-peer to get some procedures authorized, but overall, workers' comp has not been a roadblock to getting this procedure authorized. To address your other question about, I think you mentioned a partial rotator cuff and partial
biceps.
Yeah. I'm not sure if you were on when we had the video of the injection in the shoulder, but that would be one situation that's actually very, very useful. And have seen improvement. I've done several for folks that have, not perhaps not approaching a type 2 slap tear, but enough symptomatology of the biceps anchor, as well as partial biceps tear and tendinopathy that failed, to improve with physical therapy, failed to improve with injection. They don't want to take anti-inflammatories for too much longer because, when you've had folks on these medications for an extended period of time, there are other situations that can arise. And I found positive outcomes and results with that for sure. The only thing I will advise them to do is avoid any sort of platelet blocking medications for the 4 weeks after the procedure. So that would be your aspirins and your traditional anti-inflammatories.
Okay, thank you.
I would like to add one thing to the discussion on reimbursement that we're speaking on earlier, and I did need to point out John Atkinson, I know, is on the line, and he is with Apiary Medical. There are partners that have helped introduce IntraView into the DoD and VA space. So much in part to their efforts, we are fully on contract for both the VA and DoD. And I'd also say to John and many of his representatives, wish them a happy Veterans Day. Thank you for their service. But we are very excited about this partnership because providing additional tools for especially that patient population is something that we're really proud of and would like to certainly push forward. Now, what's interesting is because we speak a lot about our coverage and access, and to an extent within medicine, we're sometimes limited to utilize these tools where coverage exists. But in the VA and in that setting in particular, we can actually utilize the device based on the indication, which is use in any internal space or cavity. So there can be very broad usage in those environments where we don't have to consider reimbursement as readily once it's accepted.
Yeah.
Now, Doc, I know this is a dirty word in your practice, but can you think of any applications from the trauma perspective or things like that where this may open the door to utilization of the camera?
Well, it's almost as though you were listening to me on the phone last night, actually, because I was talking to one of my hand and wrist partners here. And he is very interested in potential utilization for wrist fractures. I know, particularly in the foot and ankle and in the wrist world, perhaps not as much in the knee world, the shoulder world, but a lot of surgeons will use a traditional arthroscope for visualization of the articular surface for confirmation that congruity has been reachieved after a fracture. So for the wrist, instead of using a traditional arthroscope, if you can get adequate visualization that the congruent surfaces are realigned once again prior to fixation, that is going to be a useful tool to minimize the risk for post-traumatic arthritis. I know for a fact that my ankle partner does ankle scopes on virtually all of his ankle fractures. But again, if you can have a situation where you're not instilling a large degree of fluid within the joint, blowing up the soft tissues, making your approach a little bit more difficult, but still get the information you need as far as reduction of the articular surface. I think that would be a very useful tool.
Outstanding. Thank you. So I'm recognizing and realizing that it is a Saturday morning, and I certainly appreciate everyone's participation. We were shooting for 30 to 45 minutes, so I will open the floor one last time very briefly if there are any additional questions for Dr. Bush while we have him on the line. We'll go for a raise of hands right now if there's anything else. And if not, I just want to extend my great appreciation for everyone who has spent some time with us here on Saturday. We're excited about the 30-degree scope. We're excited about the launch of this product, and we're really looking forward to seeing how we're able to utilize it in the field and get tremendous feedback. Please reach out to me, to your local representative, to our website, intraview.com, for additional information. And we'd like to definitely be able to participate and introduce IntraView into your practices out there in the field.
Thank you so much. Wonderful presentation.
Thank you so much. Thanks everyone for taking the time. Really appreciate it.
Thank you.
Thanks.
Thanks very much.
Bye.